Joining us virtually and in real life. This morning is the first of our 2 faculty development / wellness lectures for this semester. We'll call it the semester. I put up there the Stanford model of wellness, which divides things into culture of wellness, efficiency of practice, and personal resilience. So this semester we're focusing on efficiency of practice. So Dr. Manakas, who is our departmental informaticist, has agreed to create a lecture to help us with surgeon-specific and urology-specific tips and tricks to maybe make our time in Epic be more efficient and less painful. So without further ado.
Thank you for that introduction, Sarah. Let me get this mic on here. All right. Can everybody hear me okay? Excellent. I appreciate the opportunity to speak to the department, and it is actually really nice to be in person. As much as the drive-in seemed like a throwback to 2 years ago, it is very much nice to see some faces again in person. So this is going to be informal, and at the top of this, I want to say, there is so much I don't know about Epic. What I'm going to be presenting on today is, it seems like a very broad topic, and my apologies in advance if I'm going to disappoint you here about solving all your Epic efficiency problems. But what you'll get today are several quick tips that you may already be using. But if you're not, they have the potential to save minutes in a day, hours in a month, and you get that time back to yourself. Many of us went through a training when we first started and have had barely any since. And for some of you, that's back in 2008 when they actually launched Epic. Today, we're going to talk a little bit about the group of medical informaticists at UW Health, which I'm a part of. And while I'm blabbering on about that, you can get your laptops fired up and get Epic ready. And hopefully we'll get you some information to save some time. And I forgot to add a slide at V's discretion. I do have a disclosure from Boston Scientific as a consultant, but it has nothing to do with today's talk. All right. So there is, believe it or not, a team of hundreds of people at UW Health that helps to manage the beast that is the electronic medical record. This is a group that I'm a part of recently. In July, I took on it amounts to a few hours a week on a Tuesday morning that I have carved out to commit to meeting with what is a dynamic group of physicians across all the specialties at UW, as well as operational executives, systems analysts, and other experts that were working at UW to navigate through these changes. There is a quarterly update schedule that we adhere to, and there is definitely a priority on distributing the impact of those updates over time. Just because Epic says we have to do it, that doesn't mean, or suggests that we do it, doesn't mean that UW executes in that moment for that specific change. Of course, the rest of the management around the EMR is on all these service requests that maybe you've submitted in the past. You've got an idea for optimization or for some custom work that you think would really make a positive impact in your personal workflow. Well, as many ideas as you think you've had, there's 3,000 some providers, and they all have these ideas. And they all have unintended consequences depending on the extent of that custom work. And this committee and this governance and infrastructure in UW is devoted to navigating through what the impact of those changes might be on a revenue cycle report or the quality measures that were being tracked to verify our competence to the accountable care organization that we use to get reimbursed by Medicare. So there's a lot that goes on behind the scenes when there's a decision-making about whether or not to execute on this custom work. And then, of course, it's designed and built and tested in any number of non-production environments for Epic, at which point then it's piloted in production eventually after the majority of the quirks have been worked out, and then it's piloted in production before a wider deployment. I do want to talk a little bit about something you might hear me talking about in the future and lay the groundwork for some expectation setting around future updates. And then we'll get into the quick tips. But this is about some changes that you'll see that we've all seen, and I know I've seen them in the last 4 years since I came back to UW, but there's, it seems like something was working just fine and then they change it. I had a great workflow and I was really happy with the way this thing was working, whether it was an in-basket workflow or order placement, or they moved something. Why did they move something? We've all heard our colleagues yelling at the computer. Maybe it's just me yelling at the computer in a room by myself about what happened to the thing. More often than not, it goes back to the fact that UW was an early adopter. They were the very first institution to take inpatient Epic back in 2008. I was there. I know Williams was there. You were there too, Dr. McCackern. I see you nodding your head. Very first. And so imagine, you back in the day, you launched, your Windows 3.1, and you couldn't get what you wanted out of that to do your work. And that's where UW and the IT team worked and did a lot of custom work just to get us to do our jobs. And so they built that custom work on an old foundation, on a Windows 3.1 foundation. And now it's 14 years later, and Epic has caught up. And they've, in many ways, surpassed any custom work we might have done. And they're, one by one, deprecating some of these pieces of the foundation that the custom work was built on. Okay? So that's where, not unlike Apple or when Windows takes away the start button just to mess with you, Epic will continue to do this. And there's a constant negotiation, though, at these committees about how much do we want to fight Epic for this? Do we just accept this? And in many cases, the new stuff, the new build, the new foundation is way better, whether we realize it or not, than the old way. So just be aware of that. None of this is meant to torture any of you, and we all are impacted by these changes. But this is a huge push across the country in institutions using Epic, because we're not alone in, we've carved out these custom pathways, and now we have to kind of come back to the median, okay? All right, so this is the team of physicians that are engaged in medical informatics. You can see there's different silos, whether it's, leadership over an inpatient and ER, safety, ambulatory, population health, patient experience, clinical decision support. And then this kind of hashed out area is what I'm a part of, which is a cross-section of physicians from different specialties. And not every specialty is represented necessarily, but it's pretty broad, and it's growing. Every month there's somebody that comes and joins the group. You can see there that we happen to be lucky enough to have one of our GU oncologists who just replaced Amy Tavares, who left for Mayo Clinic. But Hamid is now the physician informaticist for oncology. So I think it's really an opportunity to collaborate on some meaningful ways to work on, standardizing some discrete data workflow for research purposes. But that's more on that to come. I just want to point that out. All right, so hopefully everybody has had enough time to get their Epic running and hasn't gotten lost completely in their in-basket as I've been talking here. But so stop checking your in-basket, stop doing your notes, and maybe we'll get you some tips to save some time. All right, number one on this list of top 10 quick tips is chart search, okay? It has been shown over and over again in analysis of physician burnout and time spent in Epic that the physicians and APPs that use chart search more spend less time in the chart. It isn't perfect. I'm not claiming that this works amazing. It's not like Google for your chart. But if you are selective about how you start looking for things in a strategic way using chart search, it'll save you time, I promise. This is great for really discrete data points, like PSA. Say you're seeing somebody new in clinic for elevated PSA, their primary care physician isn't UW, so it's not sitting there in results review. And you want to know where they've had their PSAs, or maybe they are a UW patient, but they recently changed from Dean to Courts Insurance, and you want to know where all those PSAs are. You know, we all have lived with how care everywhere seems to have gotten harder to find things, and I don't have good solutions for that, but this is a workaround. And at least gives you a heads up of, okay, this is where it's going to be. I can maybe go find it now in care everywhere. It exists, okay? So keep that in mind for some of these discrete values. Other things are just searching for urology. Maybe you get a little neurology notes, but at least it's a heads up. Have they seen urology in the past? All right. Same for urine culture, and then imaging. This is really nice to say, you know, do we have anything that I can find quickly of any imaging history? Of course, if the imported outside images haven't been linked to their Epic medical record number, then you're better off going to that PACS standalone as the source of truth. Like, is there or is there not imaging on this patient? But this is one way to quickly see, like, is it in amongst the care everywhere institutions, is it available? There's a big caveat to that, though. If the care everywhere institutions, there is no such thing as interoperability amongst electronic health records. There are attempts at it. Actually, I think it's going to be a talk that I work to try to present maybe with some other experts in the future. But because there is no interoperability, there is no consistent data sharing between institutions, you really have to be careful about these whole swaths of patients that we see from all of these hospitals listed below, none of which is available in care everywhere. Doesn't mean it didn't happen. Just means it's not available in care everywhere. So all these, you know, the Fort and Beloit being the Cerner institutions, it's maybe the most difficult because it says something might be there, but there's nothing discretely available. It just says there was an encounter. That's something, but it doesn't give you any valuable information. Some of these other institutions might as well be on paper, and some of them had been up until recently. Meditech is terrible at sharing information. So, and it's not any fault of their own. You know, Epic, whether you realize it or not, they won't even sell the EMR to these institutions because they're too small and they don't want to deal with them. And it's too expensive. You know, if these little institutions want to have Epic, they have to jump onto the UW build or to the St. Mary's build, which many of them are not in a position to do. So be careful of that. But so chart search can be really helpful in just, is it there? All right. And then it directs you towards the best, you know, an ability to trend out the data. That was really difficult to demonstrate in a non-production environment. So try it out, see what you think, and hopefully it saves you a few minutes. All right, the next one, number 2, is so ridiculously simple. And you might think, how is this possibly going to save me time? But I smile every time I do it because I don't have to move my cursor down to accept. That's how lazy I am. But the old way, right? Okay, you fill out this order, you click everything needs to be clicked, you then move down, all the way down to click accept. Or if you're staff and you know all these like alt, underline numbers and stuff, then you just have your eyes closed and you're typing. But yes, you can just right click, try it. Bring up an order, any order, and right click in any white space, unless it's a text box. Be careful about that white space. And it's the same as clicking accept. All right? I'll show it to you, just because I don't think anyone believes me. And if you do this already, again, any of these things, I'm so glad you do. You're cooler than me, because I didn't know this beforehand. All right, so this is just a non-production environment. It's a test patient, Steve. And we're going to order a scrotal ultrasound. A specific question is like, can I refer to Dan Williams for testicular pain? No, okay, then right click, that's it. Anywhere in the white space. Ready to sign. And one of the things I'll show in a second is how to bring up all these favorite orders, these diagnosis favorites. That's a tease. Okay, that's what we call in the business a tease. All right, so that's quick tip number 2 is right click in any white space when you're placing an order, and it's the same as clicking accept. All right, moving on. Number 3. This is actually what I just teased, which is, and a lot of these tips admittedly are for outpatient or ambulatory workflow. So I apologize if you're exclusively inpatient and you're looking for advice, but the majority of us in the attending position, this is where we spend all of our time documenting and is placing orders, based on in-basket messages. And this diagnosis menu, it really, you might not even know this exists. So I'm going to pull up the non-production again, this demonstration domain. Most of us realize that what used to be in the middle column here, if you have the 3-column view for outpatient encounters, there used to be a place where you could grab a diagnosis. You could front and center. That was leading to really slow load times, and it's been isolated to just this area down here, this add a diagnosis. Okay, so if anybody has their Epic open, just grab an old patient or somebody you're seeing later today and click on this button. And so this is what mine looks like. I've customized these common diagnoses to be what amounts to 90% of what I do. Your hematuria, testicular pain, Baz consults, kidney stone, all right? And if you don't see this, you can follow these very easy steps to make sure you can see this. And I don't have to search for kidney stone anymore. I don't have to search for testicle pain or about bladder cancer or prostate cancer anymore. And a lot of times it's as simple as clicking. You click those 3 lines in the arrow. That makes it go away. If you click on this chevron and just add the expand menu into buttons, well, now it's face up. If they have previous diagnoses that you've used, that'll be listed here under previous. If they have anything on their problem list, it'll show up here. But right now, this patient doesn't, this test patient. So we're going to add something to their problem list, and you'll see, well, now pain in the testicle is available if it's on their problem list to just add to your encounter diagnosis, which we're always prompted to do. You can't close the encounter unless there's a diagnosis on the encounter. Residents don't realize that. But when you are placing an order, usually you have to have a diagnosis associated with it, and this is the fastest way to do it. Yes, Sarah. So Sarah said she has a common list that's pre-populated, and if you change it, it'll stay changed. Yes, and all you need to do is to make yours look custom and to have it reflect your preferences. Wrench is the Epic speak for the gears that every other piece of software uses in 2022. So it's not find the gears, it is find the wrench. And it's going to be a theme today. So wrench that, it brings up this window that I've customized. And in any one of those fields, some multiplier of 3 works nice just based on display. You go more than 12, and they're not all face up. So if you want to have 38 diagnoses, knock yourself out. But it's You're not going to be able to see them all, which kind of defeats the purpose, because now you're scrolling again, often rage scrolling, trying to find your diagnosis. And you'll notice here the optional caption to the right is if you want to turn urothelial carcinoma of the bladder to something that is a little more truncated and fits in the box. That's as simple as it gets. So any comments or questions about that one? Anybody know about this? Yeah? Yeah, you can totally change it. Definitely spend some time on that, and you'll save yourself a lot of time over the course of a clinic day. All right, next quick tip. Oh yeah, making a note speed button. So I'm switching back and forth between the PowerPoint, but I don't really have much in the PowerPoint to show off besides turning any dot phrase into a speed button there when you're making a note. Nobody, I certainly didn't know about how much this would, whether I would use this or not, but I tried it out and I love it. It's seemingly very simple thing, you know. Well, I mean, all I was doing before was typing in keystrokes, a dot CM consult or a dot establish, and then I'd select it. But now it's just clicking any one of these speed buttons at the top. So all of those, that consult note, that established note, hematuria cysto consult, those are all just smart phrases. And again, this accounts for about, I don't know, 80, 90% of what I do in a clinic day. You can have, I have a generic telephone visit, a generic video visit that includes all the standard verbiage for compliance. Because we're often getting UroNavs that are new to UW completely, I've got a consult note plus all the UroNav documentation built in. Again, this is wrenching it to select your smart phrase and add it, but I'll demonstrate. I've got one of the things I took away was the standard prostate biopsy. So CM trust for me was trust biopsy. You can change the display, and that's it. That's how easy it is. Now, if I'm doing a prostate biopsy, I just click the button. There it is. So if you think, this is for any one of these things, I thought, I'm never going to use that. That's dumb. I made myself use it, and I feel better about it. Any one of these things I thought was nonsense as this guy is presenting them to me when I'm doing the physician builder courses with Epic. So just try it out. Just say yes. Give it a try. Take some time. Make these buttons. And I don't think you're going to regret it. All right. Saving an order favorite. Super easy. And where this really helps is if you have a panel of orders that you want to build, which if we have time at the end of this, I will go through making an order panel with you in the ambulatory setting. A lot of times there's a smart set that was built, which includes like your E&M code, your diagnosis associated, your procedure code. I don't use many of those smart sets. What I wind up using is a lot of order panels and order favorites. And let me get back to the Epic that I want to see and just show off making an order favorite. It's really easy. So for example, you want to make a prostate cancer staging CT, okay? CT abdomen pelvis. That's, let's not get that specific. This, I'm not finding the right one. I think it's this one. This is hilarious. But regardless, we'll do, let's say, oncology, prostate cancer staging. And then, sure, per protocol. Again, right click. And you just, on any order here that's in this little order basket, just click on the star. And in this display name, This is what will be searchable when you're down in the field. It's also going to be findable within a huge list of favorites. If you save a lot of these favorites, that list can become really unmanageable really quickly if you're, and I'll show that later. But so I would encourage changing the display name to something that you're going to remember. And whether it's prostate cancer staging, that way you just type that in. And if you want to get real granular, you can say where it's going to be saved in within this hierarchy of favorites on the future favorite page, but it's up to you. The indication for the exam is saved here, prostate cancer staging. Can the patient be given? Sure, per protocol. And that's it. All the other things, the schedulers take care of. And yes, apply those details to the preference list. So now that's, I can sign that. This is non-production and common. I do have prostate cancer. You can even save the diagnosis associated with given tests if you want to. And there's a lot of delays associated with this non-production. But now I can go to my favorite list, which this is actually mine that I've pared down over time. You can go to imaging and find that I did in fact save this prostate cancer staging CT. So it's visible there, but it's also findable when you just type in the search. So there it is. The other one was the one I made in practice the other day. So if you have questions about that, please don't hesitate to reach out. I'll do my best to help you with it. But it's for those really, like I have one for prostate MRI that is saved as prostate cancer suspected. I have one for HOLEP non-contrast MRI, just HOLEP pre-HOLEP staging or size assessment. One thing that I will show and is what a panel can really give you, an order panel. So it really a good order set, a good order panel is one of the best versions of clinical decision support that can positively affect the workflow of the end user. But this reminds me every time to order the PT consult. And if they don't have imaging, to order it. But you can save, like the surgical order here is just pre-populated with some basics. You know, I'm going to do a whole up. This is the size. Are they going to stay the night or not? That I have to select. But almost everything now is outpatient. I do save the post-op, which is standardized. You know, they're going to need a void trial and a what we always schedule is an 8-week telephone call with Sarah Hermson. That's their post-op. They, you know, I go through and select whether or not they have anticoagulation, some other parameters. Do they have a Foley? I'll put that in. You know, Foley change in a culture. But all of this is saved as an order panel. It's a one click. I just click hold that panel. All this comes up. It saves probably 15, 20 clicks between the PT order, the MRI if I have to do that. And when it is all accepted and you need to associate that diagnosis, well now, often I've had urinary retention on here, and you may not realize if you click the actual title of it, it selects all of them. So it's not obvious, but when you're clicking that and add that as the primary diagnosis, it'll checkbox everything. All right, so we'll move on to the next one. I'll show that later. Yes, ma'am. All right. And this is one of my favorites. And I know many of you use this already, but if you're not, you really should consider it. It's a simple keystroke that is nothing to do with Epic. It's actually a Windows functionality. But if you do a lot of Macintosh over there, a lot of Apple staring at me on all these laptops. And so there is a screenshot functionality that I use all the time on the Mac that if you do the right sequence, this is a little clunkier. But on a Windows PC, man, you can grab all sorts of stuff with just Windows Shift S. It brings up this little cursor, and anything you select goes straight to the clipboard, and all you got to do is paste, and it's back. Yeah, okay, yes, thanks. Paste, maybe. There it is. So you can increase or decrease that in size. Great for capturing images. If you want to just do a representative sample of, I grab sagittal images of the MRIs all the time for my prostates. It's really just a quick way for me to look and see what am I dealing with. And then another great thing is just trending, PSAs from care everywhere. Do that all the time. You're just trying to capture something quickly as opposed to dictating everything out. So there's no shortage of ways that this can help you save time. But the shortcut is Windows key, Shift S. It does go straight to the clipboard. Control V to paste, or just right click and paste, and you're good to go. Oh, all right. So lucky number 7. This is not to like overpromise and underdeliver, but this is going to change your life. Okay. Results and impression at the top. Back to the concept of rage scrolling. This is an old way of, actually, this is the default way in which all imaging studies are displayed. When you go to chart review and you click image, this is what it looks like by default. You got printable report, which is super helpful. That should be number 1. Hospital encounter, just there as a bold nonsense line. I really want that. And even though I've already clicked on the fact that this is an X-ray chest single view, they're going to remind me of that with this really great space-occupying, giant font line item. Oh, and then there's result information about when it was done. Then the report and order details, but it's not actually the report you're looking for. And so to get past any of this, you have to rage scroll down to where you might actually find the impression and if there were any result notes associated with that imaging. All right, well, that's the past, everybody. Okay, you got this? This is something you can do anywhere for any lab, radiology, culture report, and it turns this into this. You get your PACS links up front, your impression at the top, and the narrative right there front and center, okay? Now I see a lot of this because you're just so overwhelmed by how awesome this is gonna be, all right? But go follow these simple instructions. This gets a little Steph Dresner nerdy though. So this is the sequence that you have to change when you wrench this particular result. So any imaging result, find the wrench at the top. I'll point it out. It's circled in red over there. That's the wrench you want, okay? And get that wrench, and it comes up like this on the left as the default. And maybe you've tweaked this a little bit because you found that wrench and you clicked every wrench in Epic and you've already fixed this exactly the way you want. Good for you. But I didn't even know they were there and that this was even possible. There's a lot of gobbledygook here. Like, I don't know what 80% of this stuff means. But if you want those result notes in particular to be front and center to see, did I address this or did somebody else address this or what did I say, then definitely move that up to the top as well. But I think the PACS hyperlink, the rad impression, and the rad narrative are really high yield things to have at the top. And it's visible. It's front and center. So anybody struggling or have questions about that wrenching? Yeah. You're squinting, Dr. McKay. Oh my God. Give us just a second here. Is this an ambulatory encounter?
Yeah.
Oh, wow.
It's future though. Maybe that's the problem.
I don't think so.
So I click my wrench. These are my things. That stuff.
Are you in actual radiology?
Yeah. Oh, maybe this is GYN and not.
Oh,
Maybe this is the one that's done in GYN.
Yeah.
Okay. I'll
Yeah.
do else.
Find another patient and it'll be a little bit easier. Well, cool. So you're welcome. Your life has changed for the better. And you can spend all those hours you saved scrolling down to find the impressions over the next 10 years. You can spend that can come and curl with us next winter. Okay. All right. We're coming up on some time barriers, but next one is quick notes in a telephone encounter. I don't know how everybody else was trained. This part was somewhat nebulous in my training experience. What I'm going to pull up is this is a total playground, no real patient information, kind of useless training environment, but it allows me to show some in-basket functionality. And I was talking to the nurses the other day, and a couple months ago even, about, is there anything we can do better to make some of this in-basket management easier? And because there's a lot of sharing of patients and in-basket on their end, like if you looked at the left side of their in-basket, it's ridiculous. It's even worse than Williams. Like it's like 700 results, 832 telephone messages. It's horrible. And so now managing all that for them, a couple of these things might actually help them out. In particular, if you go to patient phone calls, and again, this is just a fake guy, Vivian, Wisconsin, who, there's a temptation here when you're getting a message to just, let's just click the reply, because that's the thing we always do when we're replying an email. We just click reply, right? Well, that creates this dithered message that isn't stored on the chart. And many of you are thinking, well, I don't want it stored on the chart. Well, a lot of people do. And they wind up just cutting and pasting whatever you're writing anyways. So how about this? And especially if you're a resident and you're trying to take a call from a patient at 2:30 in the morning, and there's this vacuum of everything that happened because it was on an RE patient or it was on a replied message, just replace that with, and this also really helps the nursing workflow, this quick note, which I didn't even know until maybe a year and a half into working, is the fastest way to just reply in line with the encounter. And it's a great opportunity to talk about lists, and so we'll build those lists in a second. But just you can add a list, your favorite pool, and the message. And then sign and send. It's that simple. But that quick note puts it in line. Apparently my name is Patty, Wisconsin. No, it's not. It's not visible. I don't know where. There it is. I think I have mine that the newest is on the top, and I was. But you can change all sorts of stuff. Again, wrenching something. And the what else was I going to say about that? Oh, the pools. Let's go back to that. Oh, real quick. If you do that quick note again, and you have this option here, this edit note in the chart, this may be my favorite way to do things when I'm calling people on their path. Is I start a telephone encounter and I edit that note in the chart, and it allows me to place some orders in that telephone encounter. Okay, and also lets me review some stuff that I might not have remembered as I'm trying to address the question. So the quick note just pops it open, doesn't let you look in the chart much and answer and reply to any particular question. What open the note in the chart does, and this doesn't have the note visible, but you expand it to the 3 panes, and now all those notes are visible. And you can edit the note, you can place orders, you can route it to people, etc. Add a diagnosis, and look at their appointment schedule. Are they going to be coming in soon? That sort of thing. So try to avoid as much as you can that little tiny, I think they made it small on purpose, but a lot of people want it. I would say it's a quick shift to just documenting in the encounter as a way to just have it findable later, so we know what happened. We know what your thoughts were. Last thing I'm going to spend a minute on is creating that pool, that list of favorite pools. And many of you have done this, I'm sure, but if you haven't, it is a real time saver to just build your own lists. And wherever you might be, whether it's in a result node environment or a telephone encounter like this list is honored. Now you can make different lists for different environments, but I just put basically everybody in the same list, and just grab your pool. What's your favorite pool? And then it becomes something that's on a drop-down menu or even face up, depending on how often you use it. And those are just a couple examples. You'll see, you click on that chevron and it disappears. What happened to it? There it is. So there's those pools that I added to the list. So you can build those, save yourself some time, and you never have to leave the mouse, at least leave the mouse later. Okay. So it's 7:41. I don't really have time to show the order panel, but I want to take an opportunity for questions. I haven't been looking at the chat at all. Dee, is there anything happening in the chat? Sure. Happy to do so. And what I'll end on is my favorite slide. We just got back on late Friday night, spent a week, and it was one of the best weeks I've had in the last 2 years. But this was the end result, this trip to Big Sky to go skiing with the whole family. It was the end result of 2 winter seasons of getting of everybody going to Cascade, as many weekends as we could, and they owned it, man. Those guys got out there and they just tore it up, and it was great. We had a great time. So I appreciate you listening to this diatribe on these quick trips. I don't honestly. I ran a couple of them by Emmy, who I know is really efficient with it, and she'd seen a few, which I was happy about. But I hope you haven't. And if you have and you use them and it saves you a few minutes, that's the best case scenario here. So I appreciate your time in listening today. And I'm, of course, available for any follow-up questions. And I may punch you to somebody who really knows what they're doing. Okay. Thanks for your time. Yeah. Oh, yeah, sure.
Great, thanks, Chris. So why don't we shift gears to red and blue indications? I believe it's Jeremiah and Rachel, or Jeremiah and whom for red and blue indications. Right. Do you guys want to load up your slides, or does Dee already have them for you? Okay. As the slides are getting loaded up, just 2 quick comments. It was great to see a lot of people last night at the retirement party for Sue Bank, one of the nurses in the urology clinic. Dr. Manakas mentioned that it was great to see everyone in person and actually give a lecture in person. And so great to see everybody out last night as well. And the second comment is this weekend coming up is the Wisconsin Urological Society meeting. And so very similarly, it'll hopefully be fun to see people in person at an academic meeting. It's here in town at the Edgewater. Dr. McCachran is president of the society this year and presiding over the meeting. So hopefully we'll get a good turnout from faculty and residents and from our urology team to support the faculty and residents presenting their academic work and supporting our society. So that'll hopefully be a fun event as well. A little bit of a format change from the last couple of years. There traditionally was a Friday evening reception, and then the meeting gets going on Saturday morning. But this year, the meeting gets going Saturday morning, then with the reception and the banquet bundled up on Saturday evening.